Good evening, everyone, and thank you for joining us for tonight's webinar with Tim Bolin, presenting Level to What. Tim Bolin, CDT, is the owner and manager of River Rock Dental Lab, located in the beautiful Traverse City region of northern Michigan. Tim combines a unique mixture of training in centric relation and neuromuscular dentistry to help solve difficult casework. Tim has trained with some of the leading clinicians such as Pete Dawson, John Cranholm, Frank Spears, and Jim Carlson. Thank you for being here tonight, Tim.
Thanks, Shay. I appreciate it. Thanks for the opportunity. All right. Well, if you want to, we're going to dive right in. So the name of this program is Level to What? It's the whole concept is we need some sort of a reference plane that when we are doing restorative dentistry or evaluating patients for what their needs may be and what that reference plane will be. Will it be soft tissue landmarks or skeletal structures? I really like to see skeletal structures because soft tissue changes, skeleton doesn't. And I'll show you some of the things that we're looking for as we move through. What reference plane should we use? Now, I want to give a very special thank you to my mentor, Dr. Jim Carlson. He was very instrumental in my background. Met Jim about 15, 16 years ago. Started working with him, supplying technical support for his denture and occlusal courses. Jim's just a great inventor and author, and he's brought to the forefront some really unique things, Aculiner being one of them. Developing the Aculiner and moving that forward so we can easily mount cases, which is a huge step forward, giving us a reference plane to work from. The planes of occlusion that we're going to talk about are Campers, Frankfurt, and the HIP plane. Now, the Campers line was introduced by Peter Camper, a Dutch anatomist, physician, and surgeon between 1722 and 1789, and is known to the dental profession for his work describing the facial angle. In his publication, he described the horizontal plane as part of the facial angle, and this anatomical reference point became known as Camper's line. It is defined as a horizontal line drawn through the lower part of the nose and the orifice of the ear. Camper's line, or Allotragus line, has been used as a reference line in dentistry for many years. According to Levin and Sauer, in a survey of complete denture procedures taught in American and Canadian dental schools, most dental practitioners determine the posterior plane of occlusion by the Camper's line. This is true in Germany, Austria, Switzerland, and the technique of using the Allotragus line to establish the plane of occlusion in prosthetic dentistry is well documented. Camper's plane has been defined as a plane passing through a casion to the center of the bony external auditory meatus. It is also described as substantially parallel to the horizon. The Frankfurt plane was first introduced in a prosthetic to prosthodontics in 1939 when it was developed by McCullum, and it was called the axis orbital plane of orientation that he justified as being horizontal or nearly so when the body is erect. The Frankfurt plane was originally an anthropologic reference adopted at an anthropological congress in Frankfurt, Germany in 1882. Frankfurt is the American spelling for Frankfurt. Unfortunately, a Frankfurt plane chosen by arbitration at the Anthropological Congress is rarely parallel to the ground in a correctly positioned head. Pitchford stated neither the Frankfurt plane nor the axis orbital plane is parallel to the reference horizontal in the aesthetic reference position. The use of either plane is a reference horizontal in a facebow transfer record will place the model of the maxilla too low in the articulator. In 1955, Cooperman and Willard began a study of more than 10,000 contemporary skulls. They searched the upper arches of attritionally occluded skulls for anatomical landmarks coinciding with a plane of occlusion in nature. Observations determined that 3 anatomical points were in this plane. The 3 points were the hamular notches and the incisive papilla, hence the name hamular incisive papilla plane, or HIP. They found these points anatomically related to the cranium. Schwartz indicated a need for scientific model analysis to standardize the diagnosis of the plane of occlusion in a uniform manner using anatomical reference points in the maxilla. He indicated these reference points of the maxilla were related to the camper's plane, defined by the hamular notches and the anterior palatine papilla of the maxilla, the HIP plane. This redefinition of camper's plane was a giant step forward from previous definitions, as the HIP plane is a stable and reproducible reference undergirded by bony support. Rich also observed a relationship between the plane of occlusion and the HIP plane. He substantiated the findings of Cooperman and Willard and found that 84% of the cases studied, the range of divergence between the HIP plane and the attritional plane was no more than 4 degrees. Karzasik and Polizek conducted a supplementary study and confirmed the observations of Rich that the HIP plane tends to parallel the plane of occlusion with a divergence between the HIP plane and the plane of occlusion less than 9 degrees. So orthocranial occlusion, Jim, I believe, coined that phrase. These are some of his drawings. He did some pretty nice drawing work. And orthocranial occlusion was occlusion that occurs when the plane of occlusion is orthogonally aligned to the forces of occlusion. It encompasses the relationship, the shape of the articular eminence of the temporomandibular joints and the shape of the plane of occlusion. Ortho, meaning straight or upright, perpendicular to or at right angles. Correction of maladjustment or deformities, straight, correct, right, and upright. Cranial, meaning pertaining to the cranium or skull. Orthogonal means pertaining to or involving right angles or perpendiculars. The ideal plane of occlusion should be parallel to a plane through the hamular notches in the incisal foramen and a plane through porion in the anterior nasal spine. Bilaterally, the ideal plane of occlusion should be parallel to a plane through the hamular notches and a plane through the articular eminences. You can see in this diagram, Jim shows that did a nice job on the drawings, I do believe. The hamular notches are very, very adamant there. Articular eminence angles are really, really important. Balanced vectors of occlusal forces are directed toward the cranial base from a 3-dimensional orthopedically correct dental arch of the maxilla. You see this nice triangle, all those occlusal forces aligned in the cranial base. When we have things that are cattywampus and just occlusion is not level, the occlusal forces are unevenly transmitted through the TM joints, causing an imbalance in the craniosacral mechanism. This results in side rotation forces against the temporal bone. The Aculiner was the instrument that Jim and his group came up with, and it allows for the accurate alignment and measurement of study models, dental prosthetics, and restorations with reference to cranial landmarks, level plane, sagittal, transverse, and horizontal planes of the skull. As a technician, what we look for is a level perspective to something. Occlusion should be level to the long axis of the body. The Aculiner acts as a tabletop or a mounting top as a level. The top surface of the mounting table acts as our level when we articulate the case with the Aculiner. That reference plane is exceedingly important to us. The Aculiner articulator is not a hinge axis articulator. You can change the vertical dimension. You can truly open the bite. The ability for the Aculiner to move in a vertical manner as well as a rotational component and advancing the mandible have some great implications. You can create a translational change to the condyles in the body of the mandible, not just a rotational change. This shows kind of the Aculiner in the skull sitting on top of it. We have the horizontal reference plane. We have the top of the Aculiner, the HIP plane, and the mounting table. So with the Acculiner, we're able to adjust the vertical component by the back set screws. We can rotate the upper hinge axis through a rotation and set a particular value there, and we can advance the mandible anterior or posteriorly. It gives us a three-way alignment of the teeth: frontal plane, mid-sagittal plane, and transverse plane. When we're establishing the plane of occlusion, the plane in the maxillary model can be related to the horizontal, sagittal, and transverse planes. We're relating it simply to the top of the mounting table and the upper hinge plate. With that, we can evaluate the frontal plane of occlusion, the anterior posterior plane of occlusion, the sagittal plane, and we can take a look at the dental arch shape. Also evaluating the transverse plane. As a technician, our goal is to create engineered occlusion. If it can be measured, it can be replicated. This gives us the ability with the Acculiner to level out the frontal plane of occlusion, have a symmetrical arch shape, and create a mathematically correct anterior posterior plane of occlusion. Getting to the mounting side of things. I don't know how many of you folks have used the Acculiners in the past or the Acculator, but it's a real simple way to mount your casework to evaluate. We're using the two hammular notches, just slight marks in red on this model, and the incisive papilla area between the centrals. Now, setting up the Acculiner for mounting, the rear scale is set to MP. MP stands for mounting position. The reason for this is the pin in the fence are 15 millimeters in height. We're typically looking for a papilla position that works to be about 10 millimeters from the tabletop. So we'll mount all of our casework at MP and then adjust it down to 0. But we place that pin and fence in their proper positions or roundabout. We line up the hammular notches on the rear fence, and occasionally I'll get a hammular notch that's real flat, so I'll put a slight indentation with an X-Acto in there so it will lock onto the fence nicely. So we simply align the fence with the hammular notches, and then we rotate the anterior segment down, allowing the pin to make contact with the incised papilla. We're going to make certain to align that pin with the line in the middle of the mounting table. That's pretty important. A lot of times in the laboratory, I will be able to evaluate a crooked midline or a shift in the midline simply by taking a look at it on the Acculiner. These shifts are picked up quite readily when we do this. But we always want to make sure that we get that pin lined up in the middle of the table as best possible. If you look down at the reflection of the pin base down below the two centrals, you can see that it is resting on the papilla. It's pulled forward to make contact with the mesials of both centrals and then centered back on that line again. Mounting stone is then applied to the upper arch. With the upper member set at MP, that's where we're mounting it at. Then we simply verify that everything is completely closed. Then the mounting's complete for the upper segment. We want to make sure that the upper member is closed and that we're still at our MP mark on the back scale. The model is then moved down to the first point of contact, and you can start your analysis from there. Now, the frontal view on this particular case shows a fairly straight midline, but it is certainly pitched up in the anterior segment. The right side view shows the first point of contact on the mesial lingual cusp of number 3. And it's pretty typical with a lot of the casework that we look at. We'll see some sort of a roll pattern with the casework. And that's where we come over to the left side. We can see that left side sticking up a little bit. That first point of contact on the opposite side at number 3. So this is where we start with, and we're going to start doing the evaluation from there. Got to decide where you're going to go with the case, but this is a great way to get started. When we're mounting dentures on the Acculiner, We're going to use a very similar mounting technique, but we're going to add just a couple of things to the case. The papillometer is a really important tool, very inexpensive. I think they run about $50, $60. But it's an important measuring device used by the dentist to gain more accurate, personalized aesthetic results in denture and denture-related implant cases. The papillometer takes the measurement of the resting lip length. It enables the dental technician to establish the anterior length of the upper anterior teeth simply, accurately, and individually for each patient. The way the papillometer is used, it's just simply placed over the incised papilla, allow the relaxed upper lip to drape down over the facial scale, and then just take a measurement. We're typically looking for about 10 millimeters is what we'd like to see. That's pretty much the average. So the average should be about 10 millimeters. And this will help decide if there is bone loss or not. If we get a reading of 14 millimeters, we would postulate that we've got about 4 millimeters of bone loss with the case, 12 millimeters, 2 millimeters of bone loss. If that's the case, we have to compensate for that bone loss. So when we deliver our bite blocks, we have the proper F point with the case. So with these, we do the exact same process. We're going to mark the hamular notches and the incised papilla. The papillometer reading on this patient was 12, which indicates approximately 2 millimeters of bone loss. So we have to shim up the anterior pin to compensate for the bone loss. With this, I'm using just some base plate wax, which is 1 millimeter thick. I'm going to use 2 pieces of the base plate wax underneath the anterior pin. So the shims are placed on the anterior pin, and we're going to make sure the vertical scale is always set at MP before we make our mounting. The hamular notches the model is placed over the hamular notches and rotated down until the papilla is in contact with the anterior pin. And we position the pin under the center of the papilla, making sure that the pin remains aligned with the line on the table. That I can't stress the line on that table. That will determine where we're going to set our anterior midline. We're going to use it on our centrals and just evaluate that. We're going to use the front of the tabletop to evaluate the facial placement relative to the 3 planes that we're trying to set our anterior teeth in. Mounting stone is added, and that's pretty much all that's needed. We're going to come back through and we're going to check to ensure that the upper member of the aculine is completely closed and the mounting was carried out with the vertical columns set at MP. Now, we're going to take that vertical column and we're going to move it down to 0. That will bring, in this particular case, that'll bring the incised papilla 12 millimeters from the tabletop. This is the position that we would fabricate our bite rims in. When you get the case from the laboratory, that F point, or the center point, should be right at the area that we want. If we're looking for let's say a female, where we're looking for 2 millimeters of reveal, we'll add a little bit of length to it. If it's a male and we're looking at 0 reveal, we won't add any additional length to it. So here's a practical application in changing vertical dimension for an overclosed denture patient. And to convert an existing or duplicate denture into orthotics, utilizing the aculiner and the HIP plane, we'll need a stable denture base, a bite registration. I typically recommend swallow bite or Gothic arch tracer, a papillometer reading, and some self-curing acrylic. Not a whole lot necessary. So again, we're coming back to the aculiner. We've got the HIP plane and the top of that mounting table. Once that case is mounted, that becomes our reference point. So we get the upper and lower models fabricated, either through relines on existing dentures, duplicate dentures, but we're going to start with some pristine model work. We're looking for clarity in the incised papilla, the hamular notches, the retromolar pads, and we need depth in the sulcuses. We're really looking for that. in our lower models. That's the way we can mount our lower models for these denture cases, looking at the depth of that sulcus and setting it about 17 millimeters for our F point. So we're going to mount the upper model as demonstrated before. This particular case really doesn't show any bone loss. So we're just going to simply set the fence, the hamular notches on the fence, and then rotate the incisor patella down to make contact with the tabletop. So there was seemingly no bone loss with this patient, so we're going to fabricate at 10 millimeters. So, but we had no tooth reveal with the patient. So the papillometer, when we moved it down to first point of contact, we only had the papilla 7 millimeters from the table, which is about 3 millimeters shorter than it probably should be. The patient had no reveal, so definitely think that F point is too short. So as we adjust this, we're going to add a little bit of length to it. This is just a lateral view of that same mounted case. So the analysis with the denture on the articulated upper shows just this typical roller coaster pattern, canted up on the left side. We've got a roll pattern on the left side as well. So we're going to correct that, give the patient some time to adjust to a new vertical position. We're going to add about 3 millimeters of vertical height to the case overall. So we're going to start with getting the lower mounted against that upper with the bite registration. Again, whatever bite registration you're comfortable with. I really recommend the swallow bite technique, a 10 swallow bite if possible, but a swallow bite technique worked quite well. So there's our upper and lowers mounted on the Aculiner. And then to level out the upper table relative to the HIP plane, we can use either a tooth-colored resin or ortho resin. In this case, we elected to just use a tooth-colored material. So we start out by placing copious amounts of petroleum jelly on the top of the table, wrapping the upper with our tooth-colored resin, closing it down, and processing that. Now, it looks a little bulky right here, and that's okay. We're going to trim that all up. So the surfaces are then shaped as necessary, and this is where we come up with our orthotic. We've got a level occlusal table now relative to the HIP plane. This has been moved down. It moved down the plane 3 millimeters to give us our 10 millimeters from the incisor patella to the tabletop, and added the 3 millimeters to the anteriors of the case. Now, once the upper is shaped, we move on to the lower arch. The lower has to be relative or level relative to the upper plane. In this particular case, we were able to reduce the lower rather than adding to it. Sometimes the lower will need to have acrylic added to it or have it processed directly against the upper acrylic. And if you have to do that, make sure you use a lot of petroleum jelly, because there's a real good chance that it'll stick. But one of the beauties of the Aculiner and the mounting system that we have here, once that lower plane is mounted against that upper, then we can take that lower model, flip it upside down, and put it in the upper member of the Aculiner. Using the same tabletop, adjust that upper member down till we've got our lower positioned exactly where we want it, add acrylic to it at that time, and process that to the tabletop, ensuring that we're not going to get any stickage between the upper denture and the lower acrylic. The lower is then finished or processed as necessary. Here you can see I just ground it down until it made contact, level contact with the upper member. So it came out this was a pretty straightforward and easy case to look at. So this is the completed dentures ready for delivery. They're completed orthotics. On the left, you can see them not cleaned up. On the right, they have been just steamed off a little bit, but nice flat planes of occlusion. Patients be able to adjust nicely to this new vertical dimension, skate out and do where they want to be until we get them locked in. Now, this is one of the things that we see a lot in the laboratory. We receive a lot of bite splints, night guards, and I will get just 2 models from a doctor with a note, please make appliance. Now that's all fine and dandy, but I don't know where I'm supposed to be or how far we're supposed to make this. Quite often when we're working with a hinge axis articulator and we need a flat plane appliance and we've got a reasonably deep overbite, let's say 5 millimeters, then opening them up on a hinge axis articulator becomes problematic. I don't know if you've ever had the experience of sending a case like that to the lab and then having results come back where they just opened it up and you've got to start grinding the bejeebers out of the case. That's just really not necessary. So what we're doing with this type of casework, we'll take this and we'll use a mathematical formula. Now we're going to make sure that everything is set on the Acculiner at 0, including the anterior posterior scale, which is on the left. The vertical scale on the right is set at MP. We're going to mount our upper cast as normal, and you can see the reflection in the pin base that have got the pin pulled up between the mesials of the two centrals. It's really important that we pull that up there and make sure that it's aligned with the front of that table. Now, as we set this up with everything as it is, the upper model is a little bit too tall to fit on the Acculiner at MP with our base plate or our mounting plate in the upper member. Simply took it over, gave myself a little bit more room. There we got the upper mounting plate in position over the upper model. Mounting plaster is added, close the Acculiner down. Same as before, we don't deviate in our mountings. Just making sure that that anterior pin is lined up with the center portion of the tabletop. So now when once we've got the upper mounted, we're going to move on to our lower. And this is the situation. This is what was sent. No instructions as far as what the opening was going to be. Just simply make U of M bite spline. So we're going to mount our lower model in MIP, or maximum intercustation. I use toothpicks and super glue to put these together. Whatever you're comfortable with using, you can use tongue depressors, popsicle sticks, but I find the toothpicks work quite well. Always going to ensure that our vertical column is set where we want it. The upper model was mounted at MP. The lower model is, we try to always mount that at 0. So we move the upper column down, making sure that the upper member is rotated all the way down into its position. We're going to mount that lower model in that position, that 0 mark. Just showing it, getting squished down. Then we'll clean it up just a little bit. This is in-house, so I don't have to make it too pretty. Now, you can see the overbite with this particular case. He's got about a 5 millimeter deep overbite. So we've got to open that up. There we are at 5 millimeters. Now, all I did here was raise the vertical column of the Acculiner 5 millimeters. That's the distance that I'm going to need to have to get a flat plane in the anterior for this case. Now, you notice the posterior opening there. I think if we were to fabricate right here, we'd have a real issue. So we're going to use a mathematical formula. Now we need to open it up 5 millimeters. So that's that MP position shows where we opened it up to get our clearance in the anterior of the case. So we've got the 5 millimeter vertical opening established. Now I want to reduce, I don't want a pure vertical opening. I want a combination of a vertical opening, a hinge opening, and I want to be able to advance the mandible. So in this particular instance, we're going to take that 5 millimeters, we're going to divide it in half. We're going to leave 2.5 millimeters of vertical opening on the Acculiner, and then we're going to use 2.5 millimeters of rotational opening. On the top of the Acculiner, there's a set screw in the back. All we do is using a gauge or ruler, we're going to open up or rotate the anterior segment of the Acculiner, open 2.5 millimeters. Now keep in mind, we reduced it 2.5 millimeters on the vertical scale, and now we're going to get our 5 millimeters with our rotational component. So we're going to open it up another 2.5 millimeters on this ruler. So now we're back to our 5 millimeters that we initially were looking for. So now we're going to advance the mandibular plate. We're going to move that AP position 2.5 millimeters forward. That's going to simulate translation as well as rotation. So the mandible's coming forward 2.5 millimeters and going up in the anterior 5 millimeters. Always looking for the scales. This set screw on the left-hand side of the Acciliner is a set screw that allows us to move the plate, the lower plate forward. So we loosen that up, we advance it 2.5 millimeters, and that's the position that we will fabricate our appliance to. So there's our vertical opening. We've got 2.5 millimeters of pure vertical, 2.5 millimeters of rotational opening, and we have 2.5 millimeters of mandibular advancement. Now, universal transfer bow. Want to get into facebow? That was HIP mounting. The Acciliner is also capable of using a facebow transfer system, and the one that I like is the UTS facebow transfer system from Ivoclar. This is it, unpackaged, pretty standard, but I like the way the whole apparatus works. It's real simple to do. Have the patient involved with the case. We're using anterior nasal spine and chorion. And I like the indicator there for anterior nasal spine. Now, in this presentation, I'm going to show you ungloved hands. So this is my wife. Nobody was hurt in this production. So here's the transfer bow as it comes out of the package. See, it's not too complicated to put together. This is my lovely wife, Karen. So the first thing we're going to do is we're going to take our bite, registration on the bite fork. So just a little blue mousse. You can use wax wafers, whatever your choice is here. They all work. So what I do is I put the transfer bow in the ears. Now I don't force them in there. I'll have the patient put their hands on the side and just push them in till they're comfortable. That's what I've got Karen doing here. She's just guiding them in there so she's nice and comfortable with everything that's going on. Setting the Nasion piece. Quite often I don't utilize this piece. I just put it in here. I don't feel it's really necessary. This whole process takes about 30 to 45 seconds to complete. So I'm having the patient hold the case or the transfer bow. Once I get the pointer right here placed on the anterior ANS, we're in good shape here. Now she can hold it up so she's comfortable and I'm not depressing that area. Here I did use the Nasion piece on this particular case. I did use the Nasion piece there. And just, I've got the pointer directly at there. So now we've got a registration joint holder that we need to connect to the facebow transfer and the bite fork. So I've got Karen holding this thing up for me. I'm going to attach, I first attach the front of the registration joint holder to the bite fork. Then the back section of the registration joint goes into this front section of the facebow transfer. So it's going, that right now it's showing it being attached to the bite fork, and this slide shows it being attached to the transfer bow. Once I've got that in there, my right hand is on a thumb set screw that is tightened down quite tightly. We don't want that set screw to move. So you might feel you're going to over tighten it, but don't worry about that. As long as we can loosen it up when we need to, we're in good shape. But we don't want to lose that position during transportation, transfer to the laboratory, or any step along the way. So we're going to make sure that's quite tight. This has got to be on your right-hand side. I cannot stress that enough. The facebow transfer will not work if you do not remember to put it on the right side. It will run into everything that we need on the articulator. It's designed with that in mind. So then we simply loosen the set screw at the top of the transfer bow, separate it, and we're done. That's as easy as it gets. Now, transferring the transfer bow and to the aculiner is a little bit more of a trick, but it's certainly doable. So there's a required accessory for this, and it's these ear cup adapters. And the aculiner was fabricated with this in mind. There are two tapped screw holes on the aculiner, and they come with Allen screws set in place. We simply remove those Allen screws and put these ear cups adapters in those areas. We set the transfer bow up in those ear cups, and we center the center locking screw in the middle of the articulator near the top is what locks the right and left sides together. So we'll tighten that down. Then we level up the transfer bow in all directions. And this shows a bubble level. You can see the two upright components in the slide on the left. Those are, it's an accessory available through Ivoclar for the transfer bow, and they are exactly for this scenario where we need to level this up on a different articulator other than their system. So we're going to level it up right to left and from front to back. And of course, we're making sure that we're doing this on a level countertop. Now, the registration joint holder is then put back into place. Now, once we've got that set screw on the right-hand side, we're not concerned with taking it off and on. If we've got that locked down, everything's going to stay in its proper position. So I'm simply going to put the joint holder back into the front position on the transfer bow. Then I'm going to position the model on the articulator. Now, typically, I would use a support in the posterior segment of this to hold that bite fork up. We're always taking a chance on the weight of the model and the mounting process. There's a possibility that it can distort and push that transfer bow down. So you can use there are multiple manufacturers of small little devices that will pop up, or you can just use some toothpicks or tongue depressors, sticky wax to the back of the bite fork to hold it in position. Mounting stone is then applied, and as before, we're always double checking to make sure the upper plate on the aculiner is completely closed and the vertical column is set at 0. This transfer model is ready to be analyzed. Now you can see pitched up in the anterior, making contact on that left molar. So where do you go with this case? At least you got a good idea. You got a reference plane to view these cases from. I think that's exceedingly important in all the casework that we do. So on the patient's left side, you see the first point of contact on that molar. Everything else is open. Now, this is, I'm going to introduce, I don't know, some of you folks probably already know about this. This is the Stratus articulator from Ivoclar. Now, this is their facebow transfer, and this is how we mount that case using their system. So we're using the anterior pins. There's two methods of doing this. We're using the anterior supports to level the case off, or the facebow transfer off on the anterior section. This is the registration joint holder, and this is the easiest way to transfer this to this particular articulator. This joint holder simply locks into the lower member of the articulator. The upper member of the articulator is put at a level position, and there is actually an anterior segment to this I didn't have available to me this particular day when I took this photo. It's an L-shaped component that goes onto the top member of the articulator, comes down and makes contact with the top of the registration joint holder. and that levels it up automatically. It's at a set vertical height. So then plaster is applied, and we've got our upper cast mounted. Now this one, I want to just show you some results of the facebow mounted results on this particular case. And then I've got, this is my wife's case, and I found this very, very interesting when I did this. I did both sides of it. The one on the left is done with a transfer bow. The one on the right is an HIP mounting. And I'll be darned, they're pretty dang close. Not much difference between those two. The HIP mounting took very, very little time to get this on an articulator. Transfer bow took a little bit more. HIP is a great way to go. So that's it.
Thank you so much, Tim. We appreciate you taking the time to present. There was a question, but I'm not.
It was, how did I know if the patient was mounted NCO? I don't. It's whatever position you're putting that patient in. It's up to the doctor to decide that. Within the laboratory, I don't have any idea as to how that patient is functioning. Are they functioning in centric relation? Are they down and forward? Where are they? We're trying to capture where the condylar position is best. So that's what we're trying to get with these cases.
And what is an indication for a need to do a facebow, or if hip is okay?
You know, I'm going to say that in about 85% of the population, the HIP plane is sufficient. In the other 15%, there are cranial distortions, maybe a forceps delivery, where you've got a distorted maxillary cast or maxillary arch. Those are areas when you know that in advance, you need to go to the facebow transfer. It's a more accurate system because we're using skeletal structure. And if you know that there's a distortion in a maxillary arch, you go right to a facebow.
Wonderful. Well, thank you again for taking the time to be here tonight and to present. We appreciate it, and a lot of good information.
Thank you very much. I appreciate y'all for sitting through this. Sorry I was a little late to the meeting, but we got it going. And any questions, don't hesitate to get in touch with me. So if anybody, doctor just asked about the accessories for the Stratus. Those are directly available directly through Ivoclar. That is an Ivoclar product. So if you have a Stratus articulator, those work flawlessly with that particular articulator. Now we do have, there's been some issues with getting Acculiners, but we do have a similar articulator called the Acculator. And the Acculator has one less movement available to it. With the Acculiner, we have two set screws on the bottom of the Acculiner where we can adjust lateral movement. We can check our lateral excursive movements on restorations with the anterior set screw, and we can make adjustments to the yaw of a case by the posterior set screw. Now, that posterior set screw has been eliminated with the Acculator. So we can do just about everything with the Acculator that we can the Acculator. Fortunately, the Acculator is no longer manufactured, but the Acculator works quite well. If anybody's interested in that Acculator, they are available through Orthodent, which is a Canadian organization in Oshawa, Ontario. If anybody would like further information, feel free to contact me. My email address is tim@rrdental.com. Try to make things pretty easy. So again, that's tim@rrdental.com.
Wonderful. And then again, this presentation the recording will be emailed to all registrants within 7 to 10 business days.
Great. Thank you very much, Shay. Appreciate you guys.
Thanks. Have a good one.
You too. Bye.